The webinar today is being recorded, so we do ask that you remain on mute during the webinar. For questions today, we have a Q&A chat box, which is at the bottom of your screen. It says Q&A. We would greatly appreciate if you could type your questions in there and not in the chat, because this is a great way for speakers to sort questions and see your questions as they come in. Next slide, please. We are offering both medical and nursing education credits. An email will be sent out later today with slides from today's webinar, as well as instructions on how to access these credits. Next slide, please. This is our disclosure statement. Please note that no speakers have any disclosures that needed to be discussed. Next slide, please. So I'd like to introduce our first speaker for today, Amelia Hammerman. Amelia has worked in the fields of public health and sexual health education for over 20 years, including 19 years with the New Jersey Department of Health Sexually Transmitted Disease Program, where she currently manages training and development, as well as other projects for the Division of HIV, STD, and TB services. Welcome, Amelia, and thank you for your presentation today.
Thank you. Good morning, everyone. Before I get into my presentation, I want to start by introducing to all the participants our new director, Toby Levin, Dr. Toby Levin. She has been with us since July as the Director of STD Services here in the Division of HIV, STD, and TB Services. She comes to us by way of Westchester, New York, and previously New York City, where she's been in public health for, I'm not even going to guess, Toby, a lot of years. You can tell us how many if you want. She's got a background in hepatitis, and she is up and running, and she is our new director. We're thrilled to have her, and she is with us all in the world of syphilis and STDs these days. So, hi, Toby. You want to say hello? Ah, Toby raised her hand. I guess there's a problem with the mic there. So, oh,
Toby, you are unmuted if you'd like to speak. Okay, I think we may be having some sound issues, Amelia.
Yeah. Okay. Yeah. All right. Okay. Well, anyway, if anybody has any needs related to STD services, Toby is there. She's great. So feel free to reach out to her. And I'm going to go ahead and start my presentation. So we're going to start with just sort of giving an overview of what's going on in New Jersey as far as syphilis goes. So this is just kind of this isn't anything super in depth. It's just to give you a picture of sort of where we are and what our trends are. So as you probably are well aware, STDs are on the rise everywhere throughout the country. So this gives you a little bit of a comparison between how New Jersey is doing compared to the United States. With chlamydia, you see, we do see a slight decrease there. However, it's important to take with a grain of salt numbers really since 2020. So 2021 numbers, 2022 numbers, 2020 numbers were definitely skewed because of COVID and, reduced ability for people to get tested, and also probably because fewer people were getting tested because they probably wouldn't unless they were symptomatic. And we don't know fully how that has impacted 2021 as well. So, but we are seeing, that great fewer chlamydia, maybe. We don't know if that's really fewer or just fewer people being tested. Gonorrhea, we are seeing an increase, not quite on the level of the United States, but nonetheless, it is still there. Primary and secondary syphilis, obviously, as you can see, we are seeing a significant increase in that over the years. And that's nationally as well as in New Jersey. And New Jersey's even growing more in syphilis than the United States. Congenital syphilis is a big concern for us, and obviously the focus of today's talk. So we went from 0 cases of congenital syphilis back in 2015, I want to say. In 2021, we were at 48 cases. We were about that last year, and we're looking somewhere in that neighborhood, maybe a little bit more this year. So although that raw number does not seem a lot, that is a big increase from where we were. And that is a big concern because, it's one thing for, adults who are making their own life decisions, and it's another thing for a baby to get a life-threatening illness. So that is a big concern for us in public health and something we definitely want to address. So just to give you an idea of what's happening in the country with congenital syphilis, the darker the blue, the more cases there, the higher the rate. So as you can see, that's quite a change from 2012 to 2021. We're seeing highly increased rates of congenital syphilis throughout the country in every state. And in New Jersey, if you look at the little New Jersey thing, you can see that we've gotten a lot darker too here in New Jersey. So that just sort of gives you an idea of how widespread and how concerning this issue is. It's not, yes, we're concerned about it in New Jersey, but it ain't just New Jersey. When we look at syphilis trends in New Jersey, we're seeing a pretty steady increase. There's some dips here, but overall, that's a really big increase. The dark blue is primary and secondary syphilis. So together, the dark blue and the green are early syphilis. So you can see how much more early syphilis we're seeing in New Jersey over the years than we have in the past. And latent as well, we're seeing a lot more cases. So this, you can see that that's, a significant trend there, and rather concerning. So when we look at 2019 to 2022, this is the top counties that we saw the most syphilis cases in were Essex, Hudson, Union, Camden, and Bergen. The northern ones, it's not surprising that we see more syphilis in the counties that have higher populations because more people, more disease. We know this. We also see more in the counties that are adjacent to large cities like New York and Philadelphia, which also isn't a surprise. These counties typically more or less have been the highest for syphilis in New Jersey for some time, but certainly now, and we are seeing more. So this is, I can't even see all of this. Oh, I'm sorry. All right, so looking at these screens, we can see that, the top ones I'm trying to see the top of that slide. So we can see here what's going on with syphilis in women, early syphilis in these counties, and we can see how high the rates are, and we can see how concerning that is. So that's something to keep in mind and look at these trends. Reported congenital syphilis trends in New Jersey. This is sort of what it looks like. So you can see we went right up there. So in 2015, we went from 0 cases, and then it was sort of a more or less even stead, and then boom, we went right up there. We went right up there, and we're not coming back down. It looks like we're not seeing a huge increase at the moment, but 2023 is not quite over. We haven't counted all our numbers, but we're not coming down, and that is certainly a very, very big concern. So this chart compares the syphilis rates in 15 to 20-year-old females. No, that's 44-year-old females. That's an error, sorry. And congenital syphilis. The purpose of this is to show you how the trends compare. So as we see cases in females of childbearing age increase, then we see the congenital syphilis cases increase as well, which really isn't a surprise, because once we are seeing syphilis get more common in other populations, because historically, and even so, men who have sex with men, we do see the most cases, but we are seeing more cases in childbearing age females. And when we see that increase, it follows then that it gets to the babies, because when women who can have babies are getting more infected, they're going to pass that infection on to their babies. So that is really, that's not surprising. We expect to see that. But just to show you how those sort of trends kind of happen together and follow each other. So these are syphilis case counts by women of childbearing age by 2022. In 2022. So you can see, again, it's not surprising. We see more cases in the same county where overall syphilis rates are higher. So we are seeing in those counties some higher rates. And so that gives us sort of an idea, you know, that these trends, they're all lining up, right? Overall syphilis trends, trends in females of childbearing age, trends in congenital syphilis. So those are all lining up, and, you know, again, not surprising. So I want to take the opportunity to just do a quick review of how we report STDs in New Jersey. So typically what happens is a patient goes to the doctor's office and the patient gives them a script for lab work, or if they have a lab there, they draw the lab. And the patient might be screened because they're sexually active, so they want a routine screen because they're being responsible. If they are in HIV care or on PrEP, then the screenings kind of go along with that. There are scheduled routine screens that go along with those. Or, you know, maybe the patient has symptoms, their partner has told them that they tested positive for an STD and they need to get tested, what have you. For whatever reason, the patient wants an STD screen. So in a syphilis screen specifically. So the doctor gives them a script and they get the lab drawn and the lab does the test. The labs and providers, we are a dual report state. So any positive reportable tests are sent to the health department. In New Jersey, the reportable STDs are reportable directly to the State Department of Health. And then once we get the cases, we evaluate them. We decide which ones warrant follow-up and investigation, and we assign those out to our DIS, our disease investigation specialists, who then follow up on the cases and provide partner services, try to locate partners to also get them in for testing and treatment, and ensure that the patient also completes treatment and all of that stuff. When it comes to pregnant females, those are our absolute top priority cases to follow. And there's, you know, more detail that goes into those investigations. Then once we get all of that, we do report all of our data to CDC when it's de-identified, so that we can have nice national statistics so we know what's going on. So that's kind of how it works. That's the quick and dirty. If you want to see the actual law, you can go to chapter 57. That link there is just a handy little magnet. That's sort of just a quick document that says, tells you what diseases are reportable in what time frame and how. So the law basically says that both healthcare providers or administrators have to report within 24 hours the disease. And that comes directly to the Department of Health, the State Department of Health. Other diseases are reported to the local health departments, STDs, and and some other infections, such as hepatitis, TB, HIV, they get reported directly to the New Jersey Department of Health. We do have disease investigation specialists at the local level who work for some local health departments who also do STD case investigation as well. So again, cases are supposed to be reported within 24 hours. Our website has STD report forms, one for syphilis, one for gonorrhea, one for chlamydia, on our website. There's the link down there, and that can be found there. As you can see, the report form asks for certain information, such as treatment and symptoms. It's really important that we get all of that information for our investigation and to ensure that patients are treated, that we are staging them correctly, reporting the correct data, all of that good stuff. So all of this information is really important. Oftentimes, almost always, we follow up before a case goes to a field investigator. Surveillance follows up with the provider to ask questions, mostly these questions, before it goes to the field. So if you get a call from the Department of Health, then please cooperate and answer questions. Okay. Oh, for the love of Pete, I'm getting a restart notice on my computer, and it's not letting me. There we go. Okay, so what about HIPAA? So this is a question we get a lot. Like, well, providers aren't allowed to share private patient information. We can't do that because of HIPAA. Well, HIPAA specifically makes an exception for public health reporting. So we absolutely are able to report, to ask questions and get information about patients with regard to their infection. That is covered by HIPAA, and that's important for public health purposes. So oftentimes we call provider's office, maybe, support staff aren't very aware of HIPAA, but usually clinicians are. So we don't typically have much of a problem with it, but just so you're aware. So the laws for syphilis, just to be aware, syphilis screening is required in New Jersey by law at the first prenatal visit for pregnant patients, at the first prenatal visit and at the time of delivery. There are also additional laws for HIV. However, and we also, of course, any additional STD should also be screened for if there's any concern for that. Something that's important to be aware of is additional screening for pregnant patients. CDC, the American College of Obstetricians and Gynecologists, the American Academy of Pediatricians, along with a lot of other professional organizations, promote the recommendation for an additional screen early in the third trimester for patients who are at an increased risk. And I'm going to talk about that on the next slide about exactly what that means. It's also very important that all sexual partners of the patient's diagnosed with syphilis are also treated. Otherwise, the patient could just get reinfected. So it's really important. And no patient should ever be discharged from a hospital after delivering without syphilis labs. And any fetal demise after 20 weeks should be evaluated for syphilis. Okay, so increased risk for pregnant women. There's that list of things examples of what would mean a pregnant female or a pregnant patient, I should say, is at increased risk. And that would be a history of syphilis infection or other STIs, incarceration, sex work, drug use, multiple partners, and highlighted down there in blue, living in areas with higher rates of syphilis. So as you saw earlier, we are in an area of higher rates of syphilis. Everywhere is in a place of higher rates of syphilis. So therefore, we have issued yearly health alerts recommending early third trimester rescreening for all pregnant patients. Because if you're in New Jersey, if you're in an area of increased syphilis rates, and so we should absolutely do that. Okay, so just a quick reminder of treatment. You can go download the STD treatment guidelines. You can download an app. They have an app, which is very handy. There's a printable version, there's pocket guides, but definitely recommend that every provider, every clinician has that at the ready, so that they can refer to it when seeing a patient for STD reasons, so that they can make sure that they are following the guidelines and treating the patient appropriately and successfully. Something to keep in mind in New Jersey is we have somewhere in the neighborhood over 100,000 births. I don't even know how many live births in New Jersey, but it's over 100,000. And among something like 57 birthing hospitals. So looking for these congenital syphilis cases can be like trying to find a needle in a haystack. It can be really tough. So in order to really affect congenital syphilis and really protect these babies, protect these pregnant patients, and get these levels down, we really have to be diligent. And it isn't even just about finding that needle in the haystack, because we aren't going to find all of them, right? We really need to start clearing out the whole haystack. And that really creates a situation where we really depend on providers, we depend on public health professionals, we depend on all of us to do our part in really addressing this issue and really making sure that patients get the appropriate screenings, get the appropriate treatment, make sure their partners get tested and treated, make sure they get their re-screenings so that we can try to get back down to that 0, because that's where we should be. Absolutely. So here's some contact information for us. That's our main STD number. There's my email. That's our website where you can find more information as well as our STD report forms. And thank you. That's all I have. Are there any questions?
Thanks so much, Amelia, for your presentation. If you have any questions, please type them in the Q&A box. Amelia, we did have one question come in, and the question was, do you have a sense of what factors are contributing to these increased rates of congenital syphilis?
So I think really, and this is my opinion, the biggest reason for the increase in congenital syphilis is the overall increase in syphilis, and that it's getting to populations, to pregnant patients more. So I really think that that's the crux of it. So why are overall rates increasing? That is something many people have sort of pontificated and have theories about. And people say, well, you know, the increased hookup apps, the increased screenings for people who are on PrEP. And, you know, some people say, well, if people are on PrEP, they think they have a free card to go and have unprotected sex because they don't have to worry about it. But I think really, I think it's sort of a perfect storm sort of all of these things, as well as, you know, we saw a lot of decrease in public health funding and funding for STD clinics. So they were having to reduce hours and couldn't screen as many, you know, couldn't see as many patients and all of those things. And I think it sort of created a perfect storm. And also with the addition of the required screenings for patients on PrEP and all of that, then, you know, that could be a reflection, maybe not of more disease so much as just we're catching it more. So that is a good thing. But overall, it's, you know, all STDs have been increasing. And I think that's just the perfect storm of all the things that I just mentioned.
Thanks so much, Amelia. And yes, there was another question that came in that says, will slides be sent out? Yes, slides will be sent out at the end of the webinar later today, as well as instructions on how to access your CE credits. We did just post Amelia's email and phone number in the chat as well, so that everyone has access to that. Well, thank you so much, Amelia. We really appreciate your presentation and presenting for us today. If you want to stop sharing your slides, we will then switch to our next presenter, Dr. Jason Zucker.
Yeah, I see a hand up. I don't know if there's one more question before I start.
If you have a question, it would be great if you could type it in the chat box. I can unmute this person if there's a question. Austin, it looks like you had your hand up. Did you have a question?
I'm so sorry, I hit that by accident.
That's okay. Don't worry.
No worries. I just wanted to make sure we didn't ignore anyone in case there was a question. And Gary, you see my slides all right?
I do. It looks great. Thanks, Jason. Okay, I don't see any other questions at the moment, so we will switch to Dr. Zucker. If there are questions, though, please type them in the box and we will answer questions again after Dr. Zucker's presentation. So for today, we have Dr. Jason Zucker, who is an assistant professor of medicine at the Columbia University Irving Medical Center. He's also the assistant medical director of the New York City STD Prevention Training Center. He is trained in adult and pediatric infectious diseases and has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. His research interests focus on how technology can be used to optimize the cascade of care for adolescents and young adults at risk of HIV and STIs. Thank you so much, Dr. Zucker, for presenting for us today.
Thank you for the introduction and good morning, everybody. And thank you all for coming to talk about this important topic. I'm lucky to be an adult and pediatric infectious disease physician. And that means I get to do a lot of consults on both mothers, fathers, and their children, sometimes all at the same time. And this is important because we're going to discuss the clinical aspects of congenital syphilis today. And managing congenital syphilis really is a family affair. Sorry, I'm having trouble advancing my slide. I have no disclosures. So the goals for today are to understand a little bit about syphilis history, microbiology, and recent epidemiology. I know some of that was covered in the earlier talk. To know the screening recommendations for syphilis in pregnancy, and to identify the clinical picture and treatment recommendations of congenital syphilis. And so if you haven't already, if you're a clinician, you'll likely find or see a case of congenital syphilis in the near future. They are increasing across the country, and we're seeing all these news reports about crazy numbers of increases. As I know was just talked about, during 2021 State of the STDs in the United States, we are seeing increasing cases of syphilis across the board, including the 74% increase since 2015, leading to this massive increase in cases of congenital syphilis. And as I'm sure was covered, the 2022 numbers were just released, showing over a 10-fold increase in just past 10 years. And that's really why I'm here to talk about the clinical aspects of congenital syphilis. The thing that's really important to know, though, is that while we know cases are increasing and we know they're this high, it didn't have to be this way. And we know that there is a path to fixing this. So before I dive in, I always like to talk a little bit about the history. In 1999, which is not that long ago, there was a national goal to reduce primary and secondary syphilis cases to 1,000 or fewer and increase the number of syphilis-free counties to 90% by 2005. And I want to give you the words they said back then because they hold very true today. As we approach the end of the 20th century, the United States is faced with a unique opportunity to eliminate syphilis within its borders. Syphilis is easy to detect and cure, given adequate access to and utilization of care. Nationally, it's at the lowest rate ever recorded and confined to a very limited number of geographic areas. The last epidemic peaked in 1990, with the highest syphilis rate in 40 years. Elimination of syphilis would have far-reaching public health implications because it would remove two devastating consequences of this disease: increased likelihood of HIV transmission and compromised ability to have healthy babies due to spontaneous abortions, stillbirths, and multi-system disorders caused by congenital syphilis acquired from mothers with syphilis. This chart shows reported cases of syphilis by stage of infection from 1941 through 2019. I placed a blue arrow over the peak from 1990 that was described in the document I just read, and a green arrow over our current day, or 2021, the last day this was updated. And as you can see, we're not that far away from the peak from 1990. And the second chart shows the same data, but only from 2012 to 2021. So you can better see the dramatic rise in cases of total syphilis during the most recent period of time. So why do we care so much about congenital syphilis? Well, there's a lot of reasons, but in this case, it's the fact that syphilis can infect the placenta and through transplacental infection affect the baby. Transplacental transmission of the fetus can occur from approximately the 9th to 10th week of gestation, and it can occur at any stage of disease. Fetal abnormalities result from a robust inflammatory response, and therefore are most pronounced after 20 weeks of gestation, since the fetal immunologic response is poorly developed in the first half of pregnancy. Congenital syphilis occurs when syphilis is transmitted from a pregnant woman to her fetus and can have devastating outcomes, including congenital infection. This includes miscarriage, stillbirth, preterm birth, impaired fetal growth, and neonatal mortality. In fact, it's recommended that any woman who delivers a stillborn infant after 20 weeks be tested for syphilis. And the risk of infection to the neonate is related to a few factors. The first is the stage of syphilis, with early stages being higher risk than later. Maternal infection later in pregnancy being higher risk. And finally, what I'll talk about many, many times today, a failure to adequately test and treat maternal infection leads to increased risk. So the diagnosis of congenital syphilis can be difficult. Maternal non-treponemal and treponemal antibodies can be transferred through the placenta to the fetus, complicating our interpretation of serologic testing. Evaluation and treatment decisions are really based on 4 steps. First, identifying syphilis in the mother. Second, determining if maternal treatment was adequate. Third, looking for the presence of clinical, laboratory, or radiographic evidence of syphilis in the neonate. And fourth, comparing maternal and neonatal non-treponemal serologic titers. And now that you know what we have to do, we're going to go through these in much greater detail. But first, I want to introduce you to 3 patients who are based on real patients, however, the details have been changed to protect their privacy. The first patient is Jen, a 34-year-old bisexual female pregnant with her first child. Her partner of 10 years is a 36-year-old bisexual man, and they're in a committed open relationship where they both have same-sex partners. She presents for prenatal care at about 10 weeks gestation. Next is Eva. She's a 29-year-old female pregnant with her first child. The baby's father does not intend to be involved, and she described him to me as a fling. She presents for prenatal care at about 12 weeks gestation. Finally, meet Alex, a 24-year-old female pregnant with her first child. She's pregnant with her high school sweetheart, and neither of them has had any other sexual partners. So who should be screened for syphilis? Well, as I'm sure everyone probably guessed by today's topic and the presentation that just happened, but they all need to be screened for syphilis. And so, like most infectious disease outbreaks, if we want to reverse the increasing number of cases, we need to test and treat more people. These are the current CDC recommendations for syphilis screening and include a variety of populations, including men who have sex with men, transgender and gender diverse people, patients taking PrEP, persons living with HIV, and non-pregnant women and non-MSM men. And finally, and the important group we're talking about today, are pregnant women. The CDC recommends that pregnant women should be screened at the first prenatal encounter, plus the 3rd trimester and at delivery, if high risk or in an endemic area. And I do encourage 3rd trimester and at delivery screening because it does seem to be where many of the missed opportunities for preventing congenital syphilis are. And many states, including New York State, have laws actually requiring 3rd trimester and delivery screening. Finally, one thing I want to highlight, because I don't want to only highlight pregnant women today, but I'm not sure that in the era of rising syphilis rates, that these recommendations actually go far enough. And you really should consider screening for syphilis anytime you're screening for STIs. And I know I mentioned before that I really routinely recommend 3rd trimester and at delivery screening. And that's because what we saw in New York. So New York actually recently changed their law to require 3rd trimester and at delivery screening. And the reason for that is that this graph, these are cases of congenital syphilis. And on the right-hand side, you see the legend about why they were missed. This green, which is far and away the largest group, were late identification of seroconversion during pregnancy. So they found in New York that for patients who are babies with congenital syphilis, the majority of cases actually occurred because of seroconversion during pregnancy, really supporting the idea of doing 3rd trimester and delivery screening. So as a reminder, again, we should be doing complete STI testing on all of our pregnant patients. While that was done here, I did cut out the additional testing for time, but please assume that they received comprehensive testing and any additional tests were negative. So in our first case, our first patient, Jen, had a reactive RPR with a titer of 1 to 1. Our second patient, Eve, had a reactive RPR with a titer of 1 to 8. And our third patient, Alex, had a reactive RPR with a titer of 1 to 1. So with our test results back, what else do we need to know to properly evaluate our patients and their future babies? So as I said before, the first step is to identify syphilis in the mother. And to do that, we need to do testing. The tests to diagnose syphilis are the same in both pregnant and non-pregnant women. There are two types of tests for syphilis: non-treponemo quantitative tests and treponemo qualitative tests. I can spend an hour plus talking about syphilis testing, but in the interest of time, as it's not the focus of today, I'll just briefly remind you that these tests can be applied in two different algorithms. The first is the traditional algorithm. And one other thing that I do want to highlight is that the testing algorithm for syphilis is really only relevant for people who don't have clinical signs and symptoms of syphilis. The traditional algorithm seen here starts with a non-treponemo test, and if positive, uses a direct treponemo test for confirmatory testing. As a reminder, a positive confirmatory test shows evidence of syphilis infection, but this could actually be evidence of a current infection or prior treated infection. And so interpreting the quantitative titers are critical for making that distinction. And we'll review quantitative titers shortly. One other thing I want to highlight is that we do have ongoing penicillin shortages now. And so making sure we adequately assess for new infection versus prior treated infection is important because it may allow us to save antibiotics for others who need them. The second algorithm is the reverse algorithm, which starts with a direct treponemo test, either an EIA or an enzyme immunoassay, or a CIA, a chemoluminescence assay. If positive, it reflexes to a quantitative non-treponemo test. And if those results differ, you perform a second direct treponemo test to break the tie. Again, while I didn't go through the entire algorithms today, I am happy to take questions about them at the end. What's important is that if you use these algorithms, you can interpret whether or not patients have a new infection with syphilis. In addition to serologic testing, there are other things to look for when worried about congenital syphilis. Fetal infection may be suspected if there are characteristic non-specific findings on ultrasound after 20 weeks of gestation. It has to be after 20 weeks because around 18 to 20 weeks is when the fetal immune system matures, and so you can get these abnormalities. Prior to that, you don't see abnormalities due to fetal immunologic immaturity. Hepatomegaly and placentomegaly are early findings, while anemia, ascites, and hydrops occur later in the course of infection. It's important to note that an abnormal ultrasound is not diagnostic of fetal infection, and a normal ultrasound does not exclude fetal infection. Now we're turning to Alex, who you may remember as having a baby with her high school partner. As neither of them has any other partners, they're convinced this had to be a false positive test. And they were probably right. Her RPR was positive, but her confirmatory treponemo testing was negative, making this likely a false positive test. False positives are more common in pregnancy. A positive low titer non-treponemal screening test can be considered a transient false positive if the confirmatory test is negative, the patient has no symptoms of syphilis, and they're at low risk for infection, like in this case where they only have a single partner. Repeating the RPR right now is likely not beneficial, as these can last for up to 6 months. All women with a false positive should have a follow-up RPR after delivery. However, for Alex, what's most important is this means that her baby does not need further workup. This is a surprisingly common question, but since her RPR was positive but her TPA was negative, she did not have syphilis, and so there's no further workup needed for the baby. So in Alex's case, we did not identify syphilis in the mother. However, what if mom had syphilis? Well, in that case, the next thing you need to know is whether maternal treatment was adequate. So how do we determine if maternal treatment was adequate? Well, we need to know about symptoms at the time of diagnosis and history of prior testing for proper staging. We need to know the number and timing of any treatment given to confirm appropriate treatment And finally, we need to think about the chances of reinfection, including whether the patient's partner was treated. So let's go back to our patient. Going back to Eve, her labs were notable for a positive RPR titer of 1 to 8 at the end of her first trimester. Confirmatory testing did return positive. We took a detailed history and found that she had never had any symptoms, but had also never been tested for syphilis before. So what stage is she and what treatment does she need? Now, before we get to treatment, understanding adequate treatment requires us to understand the proper staging of syphilis. Staging is directly related to how much medication we treat. And this diagram is from the New York City STD Prevention Training Center and New York City Department of Health Syphilis Monograph, and really highlights the stages of syphilis well. It starts with the incubation period. After recent exposure, you may not test positive and have no symptoms for up to 90 days. Therefore, pregnant women who are sexual contacts of partners with known or suspected syphilis should be considered for presumptive treatment as opposed to waiting for a test and treat strategy. After exposure or the incubation period is primary syphilis. Primary syphilis is defined by local symptoms. Traditionally, the painless chancres we think of as typical for syphilis that occur at the site of inoculation. As a reminder, primary syphilis is local. It generally presents with 1 or more ulcers at the inoculation site. It's important to remember that these are painless ulcers, which means if they're not in an easily visible spot like the rectum, vagina, or oral cavity, they may not be noticed. And so patients may test positive without ever having seen their chancre. They're often associated with regional or bilateral lymphadenopathy, which may represent an additional clue. It also reminds us the importance of doing a complete physical exam in order to best stage syphilis. Primary syphilis is highly infectious and generally resolves in about 1 to 6 weeks, whether or not you get treatment. One thing I do want to highlight is we are seeing more and more atypical presentations of syphilis. So we classically think of syphilis as the painless ulcer or chancre at the site of inoculation, but we are seeing more and more multiple atypical lesions or even painful lesions at the site of infection. As always, it's a great reminder that syphilis really is the great imitator, and we always need to have a high index of suspicion to not miss cases. After primary syphilis is secondary syphilis, which is disseminated symptoms. This is what we traditionally think of as rashes on the palms and soles, but it also includes other disseminated symptoms like disseminated rashes, generalized adenopathy, fevers, chills, fatigue, hepatitis, and other symptoms. It generally occurs 4 to 8 weeks after infection, resolves in 6 weeks, and is highly infectious. This is a table from the monograph I mentioned earlier that outlines some of the many potential manifestations of secondary syphilis. Finally, latent syphilis, which we mentioned briefly earlier, but latent syphilis is by definition asymptomatic. Early latent syphilis is when it's possible to document non-reactive syphilis serology within the past year, or a history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or syphilis of unknown duration. And these designations are important because they determine what is adequate treatment for syphilis. Just one more reminder, because this comes up all the time, latent syphilis requires no exam findings of primary, secondary, or tertiary syphilis. If you have findings of primary or secondary syphilis, then your patient does not have late latent syphilis. So after diagnosing and staging syphilis, we need to determine if maternal treatment was adequate. So what do we need to know? Well, as we discussed in great detail, you have to stage the disease using symptoms at the time of diagnosis and a history of prior testing. You need to confirm treatment, including the number and timing of any doses given. And finally, you need to assess whether or not partners were treated and if there's a chance of reinfection after the most recent treatment. And all of what we've played so far plays into treatment for syphilis. Here are the CDC recommended treatment and alternative treatment options. For incubation, primary, secondary, and early latent syphilis, it's a single dose of benzene penicillin G, or alternatively 14 days of twice daily doxycycline. For late latent, or syphilis of unknown duration, or tertiary syphilis that's not neurologic, it's benzene penicillin G weekly for 3 weeks, or doxycycline 100 milligrams twice daily for 28 days. And finally, for neuroocular and otic syphilis, it's IV penicillin for 10 to 14 days or IM penicillin for 10 to 14 days. However, one thing we need to highlight is that it's not this way for pregnancy. We do not use alternative regimens in pregnancy. And for women with a history of penicillin allergy, they actually recommend desensitization and treatment with penicillin anyway. This is because the non-penicillin regimens are either contraindicated in pregnancy, like doxycycline, or lack sufficient data for efficacy, like ceftriaxone, and do not cross the placental barrier completely, like azithromycin, and therefore are not recommended for pregnant women. Otherwise, treatment looks just like that for non-pregnant patients. With that said, there is one additional caveat. The CDC recommends considering additional therapy for women who have primary, secondary, and early latent syphilis with a second dose of PenG 1 week after the initial dose. I'll be honest, this is based on PK/PD data that showed altered penicillin levels in pregnant women. There's limited efficacy data and no randomized controlled trials, but prior to the penicillin shortage, I was generally recommending it be done. A very common question that often comes up is missed doses and how many missed doses are acceptable. In general, in non-pregnant patients, an interval of 7 to 9 days is preferred, but clinical experience suggests that 10 to 14 days between doses might be acceptable before restarting a latent syphilis treatment from scratch. However, in pregnant women, missed doses greater than 9 days are not acceptable, and pregnant women who miss a dose by greater than 9 days should actually repeat the full course of therapy. With that said, right now, everything's a little bit trickier because the FDA is reporting a shortage of benzathine penicillin G with an estimated recovery time as early 2024 as of right now. What's really interesting is that unlike prior shortages, this one is being driven by increased demand. That's likely because we're having increasing cases of syphilis, but additionally, we've seen increases in the use of penicillin for group A strep. What this means is because it's a demand issue and not a production shutdown, that benzathine penicillin G is being produced, and it's possible to get supplies, although many orders are not being fully filled, and it really affects how we're managing this shortage. One other thing I want to mention briefly is that I did mention procaine penicillin earlier, and that it could be a potential alternative. However, as of June of this past year, it was actually discontinued by the manufacturer, and so this will not be a potential option moving forward. And that puts us in a really uncomfortable position for trying to treat syphilis in terms of our recommended options. Benzathine penicillin is on shortage, intramuscular penicillin is no longer manufactured, and oral doxycycline is not used in pregnancy. So we have very limited options. So we really need to focus on managing syphilis during the shortage. And this includes a few steps. The first is monitoring supply and forecast need. Make sure that you have enough syphilis, you have enough benzathine penicillin for your expected need. And if you don't, you need to be able to figure out where you can avoid using it. Second is, and possibly the most important, is appropriately staging syphilis. As I've mentioned a few times, a thorough physical exam can help stage syphilis. Primary lesions may be hidden inside the mouth, anus, or vagina, and signs of secondary syphilis may be found on the skin, mouth, or anogenital area, and the rash can be subtle. However, if you find evidence of primary or secondary syphilis, you can do just a single shot of penicillin G as opposed to 3 shots, saving 2 dosages. Finally, in addition to appropriately staging syphilis, is prioritization. As I've said a few times, there is no alternative treatment option for pregnant women. And so think about using doxycycline when you can for non-pregnant persons, while preserving penicillin for pregnant persons as needed. This is just an example of some of the recommendations we did at our institution based on the ongoing shortage, where for pregnancy, we obviously continued benzathine penicillin for all patients. But for all others, we actually recommended doxy for syphilis exposure, as well as for latent syphilis, while based on existing supply, kept using benzathine penicillin for primary, secondary, and early latent syphilis, as well as for tertiary syphilis. And again, we had plans to modify that if we were unable to get more doses to reduce the use of benzathine penicillin even further. So let's go back to some of our example patients and see if treatment was adequate. So based on what we just reviewed, Eve was diagnosed with latent syphilis of unknown duration. and receive penicillin G intramuscularly weekly for 3 weeks. However, one additional thing you may need to understand to properly state syphilis that we didn't cover yet is how to interpret RPR titers. In the case of Jen, her RPR returned reactive with a titer of 1 to 1 and a positive confirmatory test. However, when you obtain prior records, Jen was actually diagnosed with early latent syphilis and treated 1 year ago with a titer of 1 to 64. She actually got 3 shots of penicillin G exactly 7 days apart. So does this positive test mean she needs to be treated again, or is she fully treated? So for that, we need to understand treatment failure. Treatment failure is defined as persistent recurrence of signs and symptoms or a sustained greater than 2 times dilution following treatment. Primary and secondary is a failure to see a 4-fold decrease after 12 months, while latent is failure to see a 4-fold decrease after 24 months. What's important to know, though, is that even in primary secondary syphilis, 10 to 20% will not achieve a 4-fold decrease within 12 months. And in latent syphilis, failure is more common if the initial titer is less than 1 to 8. I really bolded the timing because syphilis titers change slowly. A majority of women will not achieve a 4-fold increase or decrease in titers before delivery, although that does not indicate treatment failure. So while you may not see evidence of treatment failure, interpreting syphilis titers are important, as they're what allow us to assess for reinfection when there are no clinical symptoms. Non-treponemal antibody titers like the RPR are really what we use to follow treatment response and look for evidence of reinfection. Quantitative testing involves the serial dilution of serum specimens to determine the amount of non-treponemal antibody present. So this is always tricky, and so I like to use this chart to explain it. But a 4-fold increase in the non-treponemal titer after treatment is always abnormal. A 4-fold change in titer is equivalent to a change in 2 dilutions, which is necessary to demonstrate a clinically significant difference. So for example, if you go from 1 to 16 to 1 to 32, that's only a 1 dilution change or a 2-fold increase or decrease in titers. Compare that from going from 1 to 8 to 1 to 32, or 1 to 32 to 1 to 8, which is a 2 dilution change or a 4-fold increase or decrease in titers. Non-treponemal test titers usually decline after treatment and might become non-reactive with time. However, in many people, non-treponemal antibodies persist for a long period of time, a response referred to as the serofast reaction. So because Jen's titer had gone from 1 to 64 to 1 to 1, it had reduced by more than 4-fold or 2 dilutions, and she was considered adequately treated. Her titers are not consistent with a new infection, and she does not need any further treatment. However, Jen returned at 32 weeks. She was asymptomatic, but repeat screening labs were notable for a reactive RPR with a titer of 1 to 16. This did represent more than a 4-fold increase and is consistent with new infection. Also important to highlight why it's important to do 3rd trimester screening. She was treated with PenG 2.4 million units intramuscularly for early latent syphilis. And now that we hopefully all understand syphilis in the mother, I do want to talk about their babies. The Red Book is very clear that no newborn infant should be discharged from the hospital without determining the mother's serologic status for syphilis. And so we've covered the mother as identification of syphilis and adequacy of maternal treatment in the first 2 steps. But the next steps focus on the children themselves. So the pathophysiology of congenital syphilis is fascinating. At the onset of congenital syphilis, spirochetes are freed directly into the circulation of the fetus, with widespread dissemination to almost all organs. The clinical manifestations result from the inflammatory response and can be varied and widespread. The first step is looking for clinical symptoms, and these are just some of the most common manifestations of clinical syphilis, the congenital syphilis. Hepatomegaly occurs in almost all infants with congenital syphilis and associated with jaundice and cholestasis, as well as elevated liver enzymes. Syphilitic rhinitis or snuffles usually develops during the first week of life. It's more severe and persistent than the nasal discharge of the common cold. The nasal discharge actually contains live spirochetes and is contagious and can transmit infection by direct contact. The bold ones here all contain spirochetes that can be infectious and require contact precautions. An exam looking for congenital syphilis really needs to be complete because it can really affect any organ. I also put some of these classic images from the CDC, including rhinitis with mucopurulate nasal discharge or snuffles, and the typical desquamating and maculopapular skin lesions, punched out pale blistered lesions mainly on the ears and nasal bridge, and desquamation of the palms and soles. Hepatosplenomegaly and jaundice in an infant with congenital syphilis is seen here on the left. The black markings indicate liver margins. An X-ray of bony abnormalities, including syphilitic metaphysis in an infant with diminished density in the ends of the shaft and destruction at the proximal end of the tibia. Hmm. Sorry, buddy. All right. And there are many more symptoms I'm not going to go into today. However, again, this is a page from the syphilis monograph that really outlines them all and is available for free on the PTC website. One thing to know is you don't necessarily have to have congenital symptoms, especially at birth, to have congenital syphilis. This slide shows the proportion of individuals with congenital syphilis who are alive without documented signs and symptoms, which is the largest green area. Then there's alive with some signs and symptoms, which is the lighter green area, and infant deaths and stillbirths, which are the blue areas. In addition to clinical signs and symptoms, you also have to look for lab signs of congenital syphilis. These can be subtle findings like anemia, thrombocytopenia, leukopenia, leukocytosis, or CSF abnormalities, or reactive CSF VDRL. And finally, radiographic findings, which are not common at birth but can occur a little bit later on. Things like periostitis, metaphyseal serration, and destruction of the upper medial tibia, which are really diagnostic for congenital syphilis. And the final piece of information you need to put this puzzle together are really a comparison of maternal and neonatal non-treponemal titers. These need to be from neonatal serum and not cord blood due to contamination from maternal blood in the cord. And the goal is really to compare maternal titers and neonatal titers with a focus on whether the infant is fourfold higher than mothers. And so now that we've reviewed the workup for the babies, what will each of these babies need after birth? So as a reminder, Jen had a new syphilis infection during pregnancy, was treated with intramuscular penicillin at 32 weeks. However, baby was born prematurely at 34 weeks via C-section due to fetal distress. The baby's exam at birth was normal. Eve was diagnosed with latent syphilis of unknown duration, treated with penicillin weekly for 3 weeks, starting at 12 weeks gestation, and retested at 28 weeks. At that time, her RPR titer was down to 1:1. Her baby was born at 38 weeks via normal spontaneous vaginal delivery with a normal exam. Finally, Alex was not treated as she had a positive RPR and a negative TPA. She was diagnosed with a false positive RPR, and her baby was born at 40 weeks via C-section for failure to progress with a normal exam at birth. And so now we need to pull this all together and review the management of infants less than 4 weeks of age. Based on our evaluations of mom and baby, there are 4 potential scenarios, and these scenarios help us decide what further evaluation and treatment will be necessary. I think that proven or highly probable is the easiest criteria. In the case of a mother who tested positive during pregnancy, if the baby has an abnormal physical exam consistent with congenital syphilis, a serum quantitative titer greater than 4-fold the maternal titer, or evidence of direct detection of treponema pallidum like on dark field microscopy, the baby has proven or highly probable congenital syphilis. And because of that, the workup is extensive. It includes a CSF analysis for all patients, including cell count, protein, and VDRL, CBC and differential, and a variety of other tests is clinically indicated, although many of these do happen in practice. In terms of treatment, the general treatment is aqueous crystalline penicillin G, 50,000 units per kilogram, IV, every 12 hours for the first 7 days of life, and every 8 hours thereafter for a total of 10 days. Because this is proven or probable treatment, the entire course should be with penicillin, and if more than 1 day of therapy is missed, the entire course should be restarted. An alternative therapy used to be procaine penicillin. However, as I mentioned earlier, that is no longer available. Our second scenario is a little bit more complicated. It starts with a mother testing positive during pregnancy, but in this case, the baby has a normal physical exam and a reassuring quantitative non-treponemal titer that's less than or equal to 4 times the maternal titer. But there are one of the following concerns. Mom was not treated at all. Mom was inadequately treated, which includes using a non-penicillin regimen. The mother has no documentation of receiving treatment, or the mother received appropriate treatment, but it occurred less than 4 weeks before delivery. In the possible category, the recommended workup includes a CSF analysis, CBC with differential, and possibly long bone radiographs. In terms of treatment, the treatment is very similar to before, with aqueous penicillin G for a total treatment course of 10 days. However, in this case, there is a second option of IM benzazine penicillin as a single dose. So probably most people would prefer a single dose rather than 10 days in the hospital of IV therapy. So how do you choose between the two? In the possible category, the recommended workup include the CSF analysis, CBC, and long bone radiographs, as I mentioned before. And you should choose 10 days of treatment if the workup is abnormal, the workup is uninterpretable, for example, a CSF contaminated with blood, the workup is not performed, as for example, in some cases, you may just elect to do 10 days of therapy, or there's uncertain follow-up. If all of that is normal, you could do single dose therapy. I will also add, though, that neonates born to mothers with untreated syphilis at the time of delivery are at increased risk for congenital syphilis, and a complete IV course is often considered for those patients. So going back to our patient, the baby was born at 34 weeks gestation via C-section for fetal distress, but after birth required only stimulation with APGARs of 7 and 9. The baby was appropriate for gestational age and the exam was unremarkable. The baby's RPR titer was 1 to 2, and mom's titer was 1 to 8, down from 1 to 16 3 weeks ago when she was treated. However, given that mom was treated less than 4 weeks before delivery, she falls into the possible category. In this case, a workup was attempted, but unsuccessful due to a bloody LP, and the baby was treated with 10 days of IV penicillin therapy. I'll also note the baby initially got 48 hours of ampicillin and gentamicin for a rule-out sepsis, followed by the full 10-day course of IV penicillin. The third scenario is that of a normal physical exam, serum quantitative non-treponemal titer, less than 4-fold the maternal titer, and all of the following. Mom was treated appropriately during pregnancy. Treatment was greater than 4 weeks before delivery, and mom has no evidence of reinfection or relapse. In this case, infection is less likely and no evaluation is recommended. And there are 2 treatment options. One is benzazine penicillin 50,000 units per kilogram per dose times 1, which is what many people do. A second approach involves not treating the infant, but rather providing close serologic follow-up every 2 to 3 months for 6 months. This is a little more intensive approach, but is an option especially for mothers who may be hesitant about giving an injection to their child. And this is what happened with Eve, whose baby was born healthy at 38 weeks gestation via normal spontaneous vaginal delivery. The baby's RPR was 1 to 1. And given that mom was adequately treated more than 4 weeks before delivery, we did not perform any further workup and gave the baby a single dose of Pen-G. And finally, the last scenario, unlikely. And in this case, the baby has a normal physical exam and serum quantitative and non-treponemal serologic titer less than 4-fold the maternal titer, as well as both of the following. Mom's treatment was adequate prior to pregnancy, and mom's titer remained low and stable during pregnancy and delivery. In this case, because infection is unlikely, no evaluation is recommended, and there's no need for any treatment. However, they do recommend following infants with reactive non-treponemal tests to ensure that they become negative. In terms of follow-up, neonates with reactive non-treponemal tests should receive careful follow-up exams and serologic testing every 2 to 3 months until the test becomes non-reactive. In the case of patients not treated at birth because congenital syphilis was less likely or unlikely, non-treponemal antibody titers should decline by 3 months of age and be non-reactive by 6 months, indicating that the reactive test was caused by a passive transfer of maternal antibody. At 6 months, if the non-treponemal test is non-reactive, no further evaluation is needed. If it's still reactive, the infant may be infected and should be treated with a 10-day course. For neonates treated at birth, the non-treponemal titer should be non-reactive by 12 months, and if still reactive, consider an LP and a course of IV penicillin. For neonates with a negative non-treponema test at birth whose moms are seroreactive at delivery, they should be retested at 3 months to rule out the incubation period. And one major reminder, direct treponema tests are not used to evaluate treatment because the results are qualitative and passive maternal IgG might persist for over a year. Just one more for neonates with abnormal CSF, they do not need a repeat lumbar puncture unless they have persistent non-treponemal titers. And if they do, then you need to consult a PEDS ID expert. And that's how we bring it all together, covering the most common scenarios of children in their first 30 days of life. But there is one scenario we haven't discussed, something we see less commonly, but are seeing occasionally more often now, particularly with recent immigrants. And this is a patient over 1 month of age to be evaluated for congenital syphilis. These are generally found to have a reactive serologic test after 1 month of age, and it was not known that they had this prior to that. If congenital syphilis is possible, then an extensive evaluation should be completed, including CSF analysis, CBC, and other tests as clinically indicated. The patient should be treated with either IV penicillin for 10 days, or if the workup is totally normal, 3 doses of intramuscular Pen-G. And the reason to do all this workup is that untreated infants, regardless of whether they have manifestations in early infancy, can develop late manifestations after 2 years of age that often involve the central nervous system, bones, joints, teeth, eyes, and skin. Some consequences may not even be seen until up to 20 years of age. But late manifestations can be prevented by treatment of early infection, and so don't forget to screen and treat your patients. As a reminder from the New York City ST Prevention Training Center, we do have the syphilis monograph available online. We also have sexual health e-learning courses, including one on congenital syphilis that's already up and available that reviews a lot of the material covered here today. And with that, I'll stop and take any questions, and thank you very much.
Thank you so much, Dr. Zucker. That was a great presentation. We really appreciate that. If anyone has questions, we do encourage you to type them in the Q&A box at the bottom of your screen. Dr. Zucker, we did have 2 questions that came in. The first question is, how much does an RPR and TPPA FTA cost in commercial labs, if you happen to know?
I don't know off the top of my head, but they are traditional serologic tests, so they're not particularly expensive. It looks like somewhere between $20 and $50, depending on the lab.
Great, thank you.
Yep.
There was another question that came in asking if everyone has symptoms or can they go without symptoms? The foot and hand symptoms always happen. I know that this question came up sort of in the middle of your presentation.
Yep. So yeah, no. Latent syphilis patients do not have symptoms. And the other thing to remember is that while many patients have symptoms, because especially the chancre is painless, many patients may not notice it. And so patients either may not have symptoms or may not have symptoms they notice. Both are possible.
Great, thank you. We just have a comment that it was a great presentation.
Oh, thank you.
If there are any other questions and you are unable to type them in the box, you could raise your hand. We're happy to have you ask the question directly to Dr. Zucker as well.
We do have another question that just popped in. And it says,
Yeah.
does the mom need to complete her recommended treatment to be completely treated? And so the answer to that is kind of, we mentioned it a little bit before, but let me pull up that scenario for you guys. Here we go. So, if mom is treated even appropriately, if it's less than 4 weeks before delivery, then they fall into this possible category. If greater than 4 weeks before delivery, then it would be if it's not completed by the time of delivery, then mom is not treated. Either way, the baby's going to fall into this possible category and need some of the workup and treatment we discussed.
Great, thank you. Let's give it a moment just to see if any other questions come up. Just a reminder to everyone, we will send out all of the speaker slides later today via email, as well as instructions on how to access your CME and CNE credit. Today's webinar is being recorded and will be posted on our website sometime next week. We did have a few questions come in actually. I think it's a follow-up. Does that mean to start treatment or complete treatment?
It's complete treatment. Yeah.
Okay. And then if a mom did not have prenatal care at the day of delivery, will the babies be tested?
They should be, and moms should be tested at the time of delivery. But babies should be tested as well.
Yes, and I think Amelia did reference that in her earlier presentation. Amelia, I don't know if you're on, if you wanted to comment on that, but my understanding is that in New Jersey, babies are supposed to be tested at birth.
Good. Hi, yes, this is Amelia. Yes, in New Jersey, the law says that pregnant patients need to be tested for syphilis at the first prenatal visit and at the time of delivery. And we also recommend the additional third trimester screening.
Thank you, Amelia.
We need to be trying to mandate that part.
Okay. Another question that came in, if a mother is adequately treated during early stage of pregnancy, but shows increased titers at the third trimester screen and her partner is negative, does the mother need to be retreated or could the increased titer be related to the pregnancy?
So those types of cases get really complicated. Due to the risk of congenital syphilis, my general rule of thumb is that if it's a fourfold increase, you should treat them as a new infection regardless, and treat them the way you would a new infection. If it's a twofold increase, or one dilution change, that is within the margin of error of the test. And so that does not immediately mean that there's a new infection. In those cases, what I often do is take a really detailed history with mom. If there's any new partners or any risk for infection, I treat them. If they're really positive that there's no potential risk of infection and it's only a one-fold increase, then we repeat it again as soon as we can within like a month or so and see which direction it's going. Those ones are a lot trickier.
Great, thanks, Dr. Zucker. Okay, I don't see any additional questions at the moment. Maybe while we're just waiting, Dr. Zucker, if you don't mind, if you want to stop sharing your screen and we'll switch to Joanne and we can give the audience just a few minutes if they wanted to ask any additional questions to you. Thank you, Joanne. Okay, I don't see any other questions, but really would like to thank you, Dr. Zucker, for your presentation today. Greatly appreciate your time and participating with us and answering all these questions. Okay, and now we're going to switch over to our final speaker for today, Joanne Phillips. Joanne Simone trained as a pediatric nurse practitioner and is an educational specialist for the FXB Center at Rutgers School of Nursing. She has state and national experience working on projects to eliminate perinatal HIV and prevent congenital syphilis. Welcome, Joanne, and thank you for your presentation today.
Yeah, thank you, Gary. So today I'm going to be talking about how we're addressing the congenital syphilis issue in New Jersey using the femur HIV and congenital syphilis methodology, which I will describe. Let's see. Oh, there we go. Okay, so just a quick recap to discuss what in case you've joined after, what we've learned so far. So congenital syphilis is preventable with timely identification and treatment of syphilis infection during pregnancy. Cases of congenital syphilis are on the rise nationally, and New Jersey, particularly between 2020 and 2021, saw a dramatic increase in congenital syphilis cases, which is why we are having this discussion today. So the femur HIV and congenital syphilis methodology actually started by ACOG, the American College of Obstetricians and Gynecologists, to review and assess cases of fetal and infant mortality, which is where the acronym comes from. So it's the fetal and infant mortality review process. And it's a community-oriented process that continually assesses, monitors, and works to improve service systems and community resources for women, infants, and families where there was a fetal demise during pregnancy. That the femur system or methodology was later adapted to include cases of perinatal HIV exposure or transmission. And that was something that in New Jersey, we have been doing for about the past 10 years in Newark and Camden specifically in those locations. In the last few years, as congenital syphilis has been on the rise nationally, the methodology was further adapted to include cases of congenital syphilis. And as congenital syphilis cases rose in New Jersey, we too have included that that portion of the methodology in our systems, and I'll discuss how we have kind of revamped to move that forward here in New Jersey. So the femur system looks for missed opportunities for intervention in helping pregnant people in their healthcare, so that we can identify trends and gaps and work to improve those. So it's a continuous quality improvement system. So for HIV, we would look at the HIV prevention cascade, which includes things like identifying HIV status in women prior to pregnancy or during pregnancy, provision of antiretrovirals during pregnancy, in cases where other intervention areas, in cases where the diagnosis was later in pregnancy or there were viral loads, and there's other interventions that can be done to prevent perinatal transmission, such as cesarean section. So we look at the whole cascade of interventions that can be done and look where there were gaps or missed opportunities. For syphilis, the CDC recently released a new MMWR this past maybe 2 weeks ago. And they also were able to identify where the missed opportunities were nationally. So we also, look for those missed opportunities too. So nationally, they kind of broke it into categories, including no timely test during pregnancy, which, as Dr. Zucker pointed out, is one of the key gaps, or inadequate treatment during pregnancy. Are two of the main issues or missed opportunities. So knowing where the opportunities are for intervention to prevent cases of HIV or congenital syphilis is key. And then when we are doing the review, we look at the cases individually to see where those gaps were. Once we know where the gaps were, we start to compile them. We're looking for trends. So it's not just one case of something happening. It's the overall trends in all the cases where we're seeing, okay, this is something that is happening over again. And then we kind of compile our trends and present them to our community action team. So the femur process itself includes this following process. So there's a data gathering section. So we identified the cases. So for HIV, again, it's cases of high risk perinatal exposure or transmission. And then for congenital syphilis, it's a case of known congenital syphilis or syphilis transmission. So once we identify the case, we do a data gathering process. So that includes reviewing the medical records for the mother in the prenatal care period, any HIV care if the mother's living with HIV, the labor and delivery records, the postpartum care records, and the pediatric care record. So any of those cases that are available that we can review, we will review. And we do a maternal interview if the mother is available and willing to do an interview. It really adds a richness to the data, gives a different perspective on what may have happened in the case. The medical record is the medical record. It's the documentation from the healthcare providers, but the mother also has her own experience and perspective on what happened in the healthcare. And so when we can get a maternal interview, it really adds to our fullness context of where the missed opportunities may have been in healthcare for that particular case. So we'd like to be able to do that. Once we have gathered all that information, we do a case abstraction, and the abstracted cases, or the summary of the case, is presented to the case review team. And the case review team is a group of healthcare providers, social service providers. The clinical care team will review the case and look for the missed opportunities or trends in those cases. Once we have the list of trends, we then move on to what we call the community action team. So the community action team are stakeholders in the healthcare system. They're people who represent healthcare agencies, maternal child health consortia, substance use treatment facilities, people who have agency within the entirety of the healthcare system to make changes with those systems. And we present them with our findings for the gaps, missed opportunities that we have found, and ask them to kind of come up with solutions or an action plan for moving forward to improve the systems and make the changes. And it's a continuous quality improvement system. So once we make those changes, we see if it's had any effect in our cases year over year, that those improvements are noticeable. So FEMUR identifies local systems, weaknesses, and issues. It's used to better understand all the factors leading to an exposure or transmission. It includes and highly values inputs from mothers. It facilitates community action and improvement. It's a continuous quality improvement. It's a continuous quality improvement, model, but it's not about fact finding. It's not about assigning blame. It's not about individual agencies. It's really about trends in the healthcare system, not about individual fact finding. Fault finding, I'm sorry. So our FEMUR HIV congenital syphilis methodology in New Jersey changed in around 2021 when we saw that the increase in congenital syphilis cases had happened, and we wanted to incorporate that into the existing methodologies. So we kind of revamped, and it's now a collaboration between the New Jersey Department of Health, and they review all the congenital syphilis cases. And then our Ryan White Part D network sites are also collaborative to review the compile and review the cases of HIV transmission or high risk exposure. And then we at the FXB Center coordinate and collaborate between all of the sites and help to run the meetings, the case review team meetings, and the community action team meetings. So the process is the case review team and the community action team meeting, which we have done, and we've developed an action plan with our community action team, which I will review shortly. So I did want to go over some of our findings that we've been able to compile through this this process that we've been going through the last 2 years. So just to start with some demographics from our cases. So the majority of the cases that we have reviewed are syphilis cases only. We did have one case of co-infection and other cases of exclusively HIV. The age groups of the mothers that we have, of the cases that we have reviewed, are really across the childbearing years, spread throughout the childbearing years. So there's no one particular trend there to look at. And I am using the term mothers. All of the women that in the cases that we have reviewed have identified as female. So I am using that terminology. Race, ethnicity. So our cases that we've reviewed, we do see a racial disparity. About 60% of the cases are among Black non-Hispanic women. Another 30% are among white non-Hispanic women. And that racial disparity aligns with the disparity that we see nationally among cases of congenital syphilis, where Black African American women are the most affected in percentage of cases. The language spoken so far, English is the primary language of most of the mothers that in the cases that we have reviewed. And the vast majority of our mothers are insured on Medicaid insurance. So our missed opportunities are identified missed opportunities. The primary one, the one that we see the most, is lack of prenatal care. So complete lack of prenatal care is happens in about a third of the cases that we reviewed, where the mother did not receive any prenatal care visits. And then in another third of prenatal care visits, the mother really received inadequate care. So really late entry, very few visits during the pregnancy. So this is really a problem that we have identified that is a main contributor to our caseload in the state. But having said that, just because a mother has not presented for prenatal care doesn't mean she didn't have any interaction or engagement with the healthcare system during her pregnancy. So that's something that we're really looking at and thinking about how to affect change. So we have noticed that in about 40% of the cases, mothers did have ED visits while they were pregnant. And so that could be a missed opportunity where we would have been able to screen for syphilis and treat for syphilis during those healthcare interactions. And then among our women who are using substances, our mothers who are using substances, about 44% of those did engage in some sort of substance use treatment program while they were pregnant. And so we see that as another area where it's possible to engage people in diagnosis and treatment for syphilis infection during pregnancy. And another area that we found for missed opportunity, as Dr. Zucker alluded to also in New York, so syphilis infection that was identified at delivery after having a previous negative result or treatment in pregnancy. And that was about 20% of our cases. So as we've discussed on this webinar a few times, but I think is really important to remind everyone. So the state law in New Jersey currently is syphilis screening at entry to prenatal care, hopefully in the first trimester, but at entry to prenatal care, and then again at delivery, with the strong recommendation that third trimester testing is done. And so it's really an area where we think we can affect change in identifying cases of syphilis in either reinfection cases of syphilis or otherwise cases where the mother has had maybe late entry to prenatal care in the second trimester, but that third trimester might catch a reinfection as well. Another area that we're looking at is, or missed opportunity, is a diagnosed syphilis infection where the syphilis infection was diagnosed, but there was inadequate or not timely treatment. And that happened in about a third of the cases that we reviewed. So those would be either the mother was unable to complete the course that was prescribed to her after the syphilis infection was diagnosed, or there wasn't enough time from the diagnosis of syphilis infection to the birth of the infant to adequately treat the infection. Some other trends that we found in key social determinants in the cases that we've looked at, about half of the mothers were substance using. So again, thinking about ways that we can identify opportunities for testing and treatment in substance use treatment facilities and other agencies that interact with people who are using substances. And related to that, about half of the mothers also had interaction with the DCP&P, the Division of Child Protection and Permanency, and that is generally related to the substance use as well. About 35% of the mothers also had co-occurring mental health diagnoses, and that might be an underrepresentation because many of our mothers, as we noted, did not have any prenatal care. So the only records were sometimes brief labor and delivery records that were reviewed. So the mental health diagnoses might not be fully represented in this figure. And another trend that we're looking at is people experiencing housing insecurity and trying to think of ways that we can better support our women during pregnancy. So the major trends that we've found are one, coordination of care gaps identified among different healthcare providers. So making sure that when people receive services with different agencies, different facilities, that they're able to coordinate their care and coordinate their information provided between healthcare providers. We've seen gaps in testing, gaps in treatment and care. Again, substance use during pregnancy as a barrier to services, mental health diagnoses as a barrier to engaging in care, and gaps in community knowledge. As we described before, syphilis is kind of resurging. It's not necessarily something that people have experienced or know someone who has had syphilis. It's kind of fallen off of I think, people's radar. So really making sure that the community knows about syphilis as an STI, especially among childbearing women, and congenital syphilis, I think, is important, so that people are aware of the importance of prenatal care, early diagnosis, complete treatment during pregnancy, to prevent the negative health sequelae that can occur. So just some examples of areas that we're working on within each of the categories that I just described of our trends. So as I described before, missed opportunities for the identification of syphilis infection and linkage to prenatal care, particularly from substance use treatment programs in emergency rooms, is something that we've really seen. So making sure that we either do the syphilis testing in those arenas, or that we're able to really solidify that coordination of care between those programs, substance use treatment programs, and prenatal care providers, that were kind of working hand in hand and coordinating our care. Lack of prenatal and postpartum care, as we've seen, and a need to better engage pregnant people in prenatal care. We've also seen gaps in HIV, syphilis, and other STI testing. So we have seen cases where mothers were diagnosed with chlamydia or gonorrhea and not retested for syphilis at that time. Or also, tested for HIV, but not tested for syphilis at the same time. So really making sure that we're doing all that testing together, and not leaving out or picking and choosing different testing when one is indicated. The need to better address drug withdrawal symptoms in patients. So we have seen for substance using moms, many leaving, the hospital shortly after birth due to drug withdrawal symptoms, and not really allowing adequate time for treatment of the identified infection that was identified during the labor and delivery period. So kind of making sure that we're treating those symptoms, maybe allowing for more time to allow for treatment, because many times those mothers are quite difficult to find after they've left the hospital. So taking advantage of the opportunity when they're in the hospital to treat the infection. And we've seen in most of the cases that we really need to improve provision of healthcare and social services during pregnancy. Mothers need a lot of support, mental health support, transportation issues, childcare issues for other children, being factors in not being able to fully engage in prenatal care or syphilis treatment. As Dr. Zucker described, the treatment can be 3 doses. The treatment needs to be exact. That takes a lot of coordination. It takes a lot of transportation. If you have other children, it can be difficult. So making sure that we're really helping to have low barrier access to these services is important. And again, as I described, the need to improve community knowledge around congenital syphilis as an issue, and the reasons why it's important to engage in care and get tested for syphilis, particularly during pregnancy. But I think also, trying to decrease our community load of syphilis generally would be helpful as well. So what are we currently doing? The current action plan of the community action team stakeholders. So we're working in the arena of educating as much as we can. So here at FXB, we're developing a 3-part learning series on best practices for syphilis and STI screenings. And we are focusing on 3 arenas. outpatient settings, primarily FQHCs, in the ER, and also in substance use treatment. And CNEs will be provided for that learning series. And when it's the dates and times have been solidified, we'd be happy to announce that for people who are looking for further education. Other training will be provided. The New Jersey Department of Health and Amelia are going to be focusing on providing trainings for substance use treatment programs, beginning with residential treatment programs, Mommy and Me programs, as they're called here, for women who are pregnant or with their infants in treatment, so that they're aware of really the importance of syphilis treatment and prevention of congenital syphilis, and coordination of care between prenatal care providers and the substance use treatment providers. Utilizing state data to identify hospitals with the highest congenital syphilis deliveries and targeting those staff and providers for training. And also engaging with maternal child health regional education committees. In the state, we have 3 maternal child health consortia in the North, Central, and South. And they have education committees and tight relationships with hospitals and care providers, hospital nurse educators, managers, and directors. And so they can help to educate and train those providers as well. Also looking into ways that or projects that we can do to improve quality of care. So one of our MCH cooperatives are developing quality improvement projects, utilizing data in their regions to address disparities and improve outcomes. The Maternal Child Health Consortia have access to hospital data that they can use. And so they're working on ways that they can formulate improvement projects with their existing quality improvement committees with hospitals. There's also a pilot project in the South where they were linking patients who come into the emergency rooms to prenatal care for people who have not had prenatal care visits and attend the ER. And so looking into ways that maybe this project can be adapted to include prenatal panels, STI panels that can be done also in these ER triage settings. And then Cooper Hospital had already been able to implement prenatal testing in OB triage for patients who had not attended any prenatal care visits at the time of their visit. And so looking into if that model can be replicated in other areas as well. Policies. So the Division of Mental Health and Addiction Services is looking into how to integrate STI testing and prenatal care linkage into their substance use treatment programs. We've had meetings to discuss ways that might be done. And so they are thinking through kind of the possibilities to better integrate that testing and linkage into their grantee programs. And we have been working with government affairs to identify any legislative opportunities, government affairs at Rutgers University, to identify any legislative opportunities around our syphilis testing law, perhaps making or changing our state law to include that 3rd trimester test. So instead of it being a recommendation, it be a mandated by law. Again, other resources that our stakeholders are working to move forward. So the PTC, as one of our stakeholders, also has created a congenital syphilis self-paced learning module with CME credit that is available for providers to take at their own pace. And we are at FXB are developing some New Jersey specific provider and community infographics, specific resources for people in our state around knowledge, facts, epi and demographics, but also our local resources so that people have what they need to be able to move forward with, again, diagnosing, treating syphilis and preventing congenital syphilis infections. And any questions?
Great. Thank you so much, Joanne, for that presentation. And thank you to all of our speakers. So as a reminder to everyone on the line, if you do have questions for any of our speakers, could you please type them into the Q&A box, which you should see at the bottom of your Zoom screen. We do have a couple questions here. Joanne, one of the questions related to some of the statistics you were sharing.
Yes.
Was there inadequate treatment in patients who had received adequate prenatal care?
Was there inadequate treatment so sorry, so I have to go through 34 cases in my mind. I'm trying to think. Was there inadequate treatment in patients who had received inadequate? So yes, in the sense that there were some cases where the third trimester test was missing or not done. And so that the person was then diagnosed at delivery. So that was something that did happen in people who did attend prenatal care. Yes, in that some of the cases did have seroconversion after the third trimester test. So that would be another situation where where it was then diagnosed at delivery. And then I'm trying to think I think a third scenario where prenatal care, it dropped in and out of my head, but yeah, so yes, those are the more likely scenarios, or possibly that it was diagnosed in the third trimester, but then the person delivered early and did not have time to complete adequate treatment. So that can also happen too.
Great, thank you. And then one comment here, a thought about some of the trends that are being seen in New Jersey when you all are reviewing the cases is that for patients who don't speak English, there seems to sometimes have been a disconnect in services obtained and provided to the patients regarding syphilis and congenital syphilis.
Yes, and so you will note that most of the cases that we have reviewed, the person did speak English, but we have reviewed some cases where yes, there were persons did not speak English, and yes, some of those barriers with language, understanding, cultural knowledge around the illness can affect whether the services have been adequately obtained. Or confusion, around what was expected or what was prescribed versus what was understood.
Great, thank you. As a reminder, if you have any other questions or thoughts that you'd like to share for our speakers, please drop them in the Q&A tab. We do have a little bit more time, so I'm gonna just wait a minute and see if folks drop anything in. In the meantime, maybe Joanne and Dr. Zucker, I would ask both of you, just for folks who are on the line who may not screen often for syphilis or see a lot of syphilis, what are some recommendations you would have for those providers for whom this isn't something they do as often in their daily practice?
I don't know if that's a Dr. Zucker question, but
either or.
In terms of what? Because it's in order to do the test, it's just a blood test like we do anything else. So ordering the test, order it. Yeah, I mean, I think, like all things in STIs, routine opt-out testing is always the best. Screen patients for STIs routinely, screen patients for syphilis routinely, and all pregnant patients should be screened for syphilis as per the guidelines. So I'm not sure what else to recommend other than that. They can always reach out to help with the clinical consult line if there's anything we can ever do to help them in terms of interpretation or difficult situations.
Yeah, and I would also add, Gary, that there is support, if you have questions about past treatment or questions about mostly, obtaining records to understand how to stage the infection properly. The Department of Health is available to assist with that. And again, don't be afraid to test. It will
Great, thank you both. Fantastic. All right, we have no other questions in the chat, or in the Q&A box rather. So if there's nothing else from folks, we can begin to wrap up. Amelia, I also wanted to see if you had any last comments you'd like to leave our attendees with today before we close out.
Not really, other than please test your patients for syphilis, and please make sure that testing includes an RPR and a treponemal test, and RPRs are ordered reflex to confirmatory so that the lab can automatically run that confirmatory test in the event that that RPR is reactive, rather than ordering 2 separate tests.
Yes.
Great, thank you so much. Okay, so thank you again to all of our speakers, Amelia and Dr. Zucker and Joanne. We really appreciate you all being here and sharing your time and expertise with us. And thank you to all the attendees for taking time out of your days to be here and listen to this important topic. As mentioned earlier, an email will be sent out later today with instructions for how to claim CME and CNE, as well as the slides, which will be shared later. This presentation was recorded and will eventually live on our website, and we will be sure to let folks know once that's online. But thank you again to everyone for being here, and we hope you have a great rest of your day.